Yes, ma'am.
So are we live?
We are live now. We are live
Yeah.
now.
Further, you can start.
A very good evening to all of you. On behalf of IFS UP's chapter, I welcome you to this first episode of Journal Club of our tenure 26-28. And we are extremely delighted and honored to be with you. And we have stalwarts from the field who shall be sharing their valuable inputs with us. And we have two very enthusiastic young presenters who shall be presenting before you two very interesting papers. And we have also Dr. Mona who shall be moderating the session. So before proceeding ahead, I would like to welcome Dr. Divya Agarwal, Secretary IFS UP's chapter, to welcome everyone.
Thank you, Vardha. On behalf of IFS UP Chapter East, it gives me immense pleasure to welcome you all to on today's. This is our first General Club, and we will continue to do it on the frequent episodes 1 to 2 months. And we are doing in collaboration with KZMU unit. So I'm thankful to KZMU unit who have taken all the. Then they are ready. They have become ready to participate in this. So general clubs, we know they are the backbone of academic growth, and they allow us to basically discuss the literature. We can do the debate on it, and we can draw this inference. So what is the clinical relevance of that topic, which we can apply in our day-to-day practice? So that is the purpose of a general club. So we will be discussing two topics. One is on McCune-Albright syndrome, and second will be on DuoStim. And we have two enthusiastic participants, Dr. Arunima and Dr. Whisper, who will be taking these two topics. And I'm extremely delighted that with us, Dr. Mona Asani, she'll be moderating the session. So I'm thankful to her also. And I also like to thank the entire KGMU team and our office bearers, especially Dr. Varda, who has taken all the initiative, Dr. Arja, and all the participants, Dr. Geeta Khanna ma'am, Dr. Sunita. I would especially like to thank our esteemed experts, Dr. Ankita Khanna ma'am, Dr. Sunita Chandra, and Dr. Usha, who has taken out their valuable time to participate in this session. So without taking much time, I would like to start the scientific session. I would request Varda to continue with the session.
Thank you, ma'am. You're extremely right that journal club is an integral part of any of the societies, because it brings all the recent insights, and we are able to share their knowledge with the young, enthusiastic gynecologists, and it also gives a platform for them to come up and interact with us and share their queries and share their experiences. So before starting the first session, I take the proud privilege to introduce the experts. Dr. Geeta Khanna ma'am, she's the Director ART Unit High Risk, Ajanta Hospital, Lucknow, and she actually needs no introduction. She's such a lovable person for all of us, and she has been a constant source of support and inspiration for us. Welcome, Dr. Geeta ma'am.
Thank you.
Dr. Sunita Chandra ma'am. She's the director of Rajendra Nagar Hospital, and she was past positions. She was a past secretary of APGL, and presently she's the secretary of. She was also the secretary of IFS UP's chapter in the year 2020 to 2022. She is also very dynamic and highly academic gynecologist. Welcome, Dr. Sunita ma'am, and we are very thankful you've spared your precious time. Welcome, Sunita ma'am. I also welcome Dr. Usha Yadav ma'am. She is the senior consultant, Octavia Hospital, very active, very supportive, encouraging. She is always present in all the IFS UP's chapter CMEs and conferences, and always encourages us. Thank you, ma'am.
Thank you. Thank you, Vardha.
Also, very enthusiastic moderator of the session, Dr. Mona Asnani. She's the additional professor at KGMU, and she's actually the right person because she's young, she's dynamic, and she's also very updated in her knowledge. So she shall be moderating this first both the sessions. Welcome, Dr. Mona.
Thank you. Thank you so much, Dr. Varda. So a very good evening to all the faculty members, respected experts and participants. I sincerely express my gratitude to all IFS dignitaries, Geeta ma'am, Divya ma'am, Sunita Chandra ma'am, and Dr. Varda for giving me this opportunity. When initially this journal club was offered to us, then we were just puzzled what to present, what not to present. Then so much brainstorming with Dr. Varda and my two eligible senior residents, and we came to conclusion that we will present one common topic of common interest that is very relevant and debatable also, and one rare case report. So the first article which we included, Dr. Arunima is going to present is DuoStim. Do we have enough evidence to use it? It is from Fertility and Sterility, October 2024, and is being presented as fertile battle when both pro and con viewpoints will be discussed. And second one, Dr. Misbah is going to present. That is also very interesting and rare case report. That is fertility journey of a patient with McCune-Albright syndrome. That is associated with bilateral ovarian involvement. That is written by Kim et al., published in FNS Reports 2024. So I would first welcome our experts, first of all, Sunita Chandra ma'am, Geeta Khanna ma'am, and Dr. Usha Yadav ma'am, and invite my first presenter, Dr. Arunima, to do the needful. So first of all, I would like to introduce somewhat about DuoStim. DuoStim is a double stimulation in the single ovarian cycle. It is an attractive strategy because it promises to retrieve more oocyte in a single short time, in a single cycle. Especially in the time-sensitive patients where the patients are poor responders, where there is advanced maternal age and fertility preservation cases are there. So I would, without wasting any time, I would request Arunima to take through the article and highlight both sides of the debate.
Okay.
Welcome, Arunima.
Yes, ma'am.
Mukul, may I do the screen sharing?
Very good. Yes, ma'am.
Are you able to do the
Yes, ma'am. Yes, ma'am.
screen?
You can share.
Nee, Arunima, you want me to share these slides?
Yes, ma'am. Share the slide.
Should I share the slides?
Because I don't think they are having any
Yes,
option
ma'am.
of sharing the
Share,
slides,
ma'am.
not being visible there.
Okay. So I'll do it. So with the blessings of Ma Saraswati, we move ahead with the first presentation, which is by Dr. Arunima, and it is on DuoStim. Is my screen visible?
Yes.
Okay.
Ma Saraswati's statue is visible
Yes,
right
ma'am.
now.
It's visible.
This is not visible?
Yeah.
The DuoStim is not visible?
DuoStim is not visible.
Okay.
No, ma'am. No, ma'am. DuoStim is not visible.
Just hold on.
First of all, stop sharing, Varda, this screen, and then
Okay.
you can stop sharing and then again share the new slide.
Yeah, I got it. Thank you, ma'am. Now you've become a pro. Now is it visible?
Yeah. Now it is visible.
Yes, ma'am.
फुल स्क्रीन कर दो इसको.
Arunima, go ahead.
You can do the
Good evening,
slideshow.
respected teacher.
Slideshow.
Okay.
Yeah, this is there. Yeah.
A very good evening, respected teachers, faculty members, and my dear colleagues who have joined us in today's journal club. Myself, Dr. Arunima Shukla, senior resident from KGMC Lucknow. Today we are discussing the article, DuoStim, do we have enough evidence to use it? Here we are going to discuss both the pros as well as the cons related to the topic. Now, why this article is important? The author states that for the time-sensitive IVF patients, every follicular wave could represent an opportunity. But we have to keep in mind that this opportunity must be weighed against the evidence. The 3 points that we must keep in mind before proceeding with the dual stimulation is that, number 1, the ideal patient selection. The patient having advanced age or poor ovarian reserve or oncological timelines that tendency to accumulate oocytes quickly are the ideal candidates in whom we can proceed with dual stimulation. The second thing is clinical uncertainty. Dual stimulation is biologically plausible, but the strongest outcomes are still debated. Third is decision tension. Patient wants speed, but clinicians must counsel them on the current live birth evidence present in our journals related to dual stimulation, the cost associated with it, the lab quality, and we should tell them that there's no fresh embryo transfer possible using the dual stimulation. Next slide. So, what is the concept behind this protocol? So, in normal conventional cycles, we usually proceed with the single ovarian stimulation. But in dual stimulation, we do the 2 ovarian stimulations within the same menstrual cycle. The one stimulation is done in the follicular phase, whereas the other one is given in the luteal phase. So, the cycle is as followed. First, we give the follicular stimulation, and we move ahead with the conventional start. We give gonadotropin on day 2 and 3 after assessment of all the hormonal profile. Then we give the trigger, we do the ovum pickup, which is the first retrieval. Then between the first and second stimulation, we give, between the ovum pickup and second stimulation, we give about 5-day gap for recovery and assessment of the hormonal profile. Then we give the luteal stimulation, that is the second stimulation, and move ahead with the second ovum pickup, that is the second retrieval. And all the oocytes or embryo that are produced undergo freeze-all technique, that is vitrification. And if we want, in the same time, we can go ahead with the pre-implantation genetic testing of aneuploidy as well. So clinical implication here is it is a multi-cycle strategy compressed into one ovarian cycle, usually requiring cycle segmentation and vitrification. Next slide. So why it might work? So what is the biological rationale behind using the dual stimulation? Normally, in the traditional view is that, ma'am, please change the slide.
It's not just. Let me just check. It's not moving. Is it showing?
Previous slide, ma'am. Yes, so it's showing, ma'am. Previous slide, ma'am. Fourth number. Ma'am, one more. Yes, ma'am. So what is the biological rationale behind the next slide, ma'am? Thank you, ma'am. So what is the biological rationale behind using the dual stimulation? In conventional cycle, conventional ovarian stimulation cycle, we move ahead with one follicular wave, one dominant cohort is produced per cycle. But in dual stimulation, the multiple follicular waves are created to produce increase in number of oocytes. The good thing here that we exploit is that in oocyte that is produced using the luteal phase stimulation is also competent enough to produce the embryo. The second cohort may increase the oocyte and embryo accumulation. And the thing is that the most rationale that we are using over here applies best when time is limited or prognosis is poor. Next slide. So the points in favor of the topic, the author states that dual stimulation is a personalized time-saving strategy, ideally useful in patients who are having poor prognosis like low ovarian reserve or advanced maternal age, or in whom we require pre-implantation genetic testing for aneuploidy. The advantages are decreased time, as second stimulation can begin soon after first ovum pickup, helping patients move faster towards oocyte or embryo accumulation. The second benefit is cost and efficiency. It is mainly useful in those patients in whom we require a combination of freeze-all along with pre-implantation genetic testing of aneuploidy together. For them, we require strong vitrification and blastocyst culture to be present. Then third point is lower dropout rate. As we are immediately continuing with the second stimulation cycle, and so the patients who are having the poor outcome after the first stimulation can undergo second stimulation in the second part of the cycle. So it prevents the emotional exhaustion. So conclusion here is that it reduces the time to find a euploid embryo and time to pregnancy while minimizing the dropout. Next slide. Now, what are the disadvantages using the dual stimulation? Number one is the limited evidences available. As the studies currently available and the trials that are done using dual stimulation are mainly done using the patients who are having the poor ovarian reserve and not in the patients who are having good prognosis or normal ovarian reserve. So we cannot extrapolate the output that we have obtained from the present studies to the general population. The thing is, the number of oocytes and mature oocytes that we retrieve using the dual stimulation are good, but the clinical pregnancy rate or ongoing pregnancy or live birth rate obtained after using the dual stimulation, the evidences proving it is currently limited as compared to conventional stimulation protocol. Next. So, using dual stimulation, the more number of mature oocytes are produced, the mean difference is about increases by about 3.35 as compared to the conventional ovulation stimulation cycles. And more women are reaching at least one euploid embryo using the dual stimulation protocol as compared to the conventional cycle. When we use a dual stimulation protocol, around 33% women are having at least one euploid embryo, whereas in control setup or where we are using the conventional stimulation protocol, there 19.3% of females are having at least one euploid embryo at the end of the cycle. But evidence was unclear after the trial was completed. The evidence was unclear for the clinical pregnancy, for the live birth rate, and for the miscarriage. So, and this data is mainly for the patients who are having the poor ovarian reserve and should not be extrapolated to the general population. Next slide. So these are two random controlled trials which journal. For the one is signifying the first one is DIM controlled trial. Ovarian responders was and divided into two. The first group was given dual stimulation, the other one was given the stimulation protocol. And in those two setups, we noticed that the one who given dual stimulation, their embryo transfer rate was comparatively less, cumulative pregnancy outcomes. So overall outcome was in dual stimulation. Whereas the other article here is as given here, which is also a randomized control trial. Here, 80 women were compared, more than 38 years of were ovarian responders and pre-implantation genetic testing or annual cycles. Here, the outcomes when the women given dual stimulation, that time is shorter. That is about 3 weeks.
I think you have logged out somehow. क्या हुआ?
Slide तो
I think
visible
some
है,
network issue is there.
Slide तो दिख रही है.
Voice is not audible.
Slide तो actually डॉक्टर वारदा शेयर कर रही है ना मैम.
Slides तो मैं कर रही हूँ ना.
इस
मुझे
वजह
लग
से
रहा है network
Where is
issue है.
Arunima? Her voice is not.
We can't see her
नेटवर्क
also.
इशू है वहाँ पे.
Network issue है.
For the interruption. So who is the reasonable candidate in whom we should give the dual stimulation? After the trials were conducted and studies were done, it was found that the most probable candidate in whom the dual stimulation were given traditionally were the patients who were desiring the oncofertility before undergoing the urgent chemotherapy or treatment. The second candidates who can be given the dual stimulation are the one who are having advanced maternal age or poor ovarian reserve. The third one are the patients who require pre-implantation genetic testing and in whom the combination of freeze-all plan with pre-implantation genetic testing can be done. In the patients who are having normal reserve or a non-urgent routine IVF is being done, there the use of dual stimulation has not shown good outcomes currently in the current studies that has been done now. Next. So practical caveats before adopting dual stimulation. First of all, we need to know that there's no fresh embryo transfer that is involved using the dual stimulation. We are doing cycle segmentation followed by freeze-all technique, that is vitrification, thawing, and then we are doing the frozen embryo transfer. And second is we have to have the lab dependence. We need good vitrification setup. We need good blastocyst culture setup, and laboratory system should be good for the good outcome of the cycle. Then cost and burden. There is requirement of additional drugs, visits, and procedures that is may not be the offset in all the settings. And fourth is evidence heterogeneity. So there are various small RCTs that have been conducted using the selected population of patient and not a generalized population, and protocol differences, which limits the generalization of these, the result of these RCTs to the general population. So we can adopt a dual stimulation as an individualized option only when the expected dyne benefit is clinically meaningful. So how we will counsel the couple for whom we have to give the dual stimulation? We need to tell them that what we are doing using this protocol. That we are doing, we are using this protocol because it may help them to collect more oocytes or embryos in a shorter time. And we should also tell them that what it has not proven, that it has not conclusively shown higher live birth rate as compared to the two standard or conventional oocyte cycle. And what changes practically? Here we cannot do the fresh embryo transfer, and we are doing using the freeze-all technique, and we are going to do the frozen embryo transfer. And how we are going to decide whether this protocol is good for them or not? We'll decide depending upon their age, their ovarian reserve, the need, urgency for doing the ovarian stimulation, and then we have to do pre-implantation genetic testing for aneuploidy in them or not. And also we have to keep in mind the cost and lab capability. And we should also altogether keep in mind that faster accumulation may help the selected patients, but it is not a guarantee of better outcome. So critical appraisal for this general club are: number one, the comparator. Should dual stimulation be compared with one conventional stimulation cycle or with the two conventional cycles? What should be the end point? Are oocytes number enough to decide the end point for the trial, or should we keep in mind about the live birth rate, clinical pregnancy outcome as well? Then selection bias. Were second stimulation candidates pre-selected by follicle visibility or prior response? Then generalizability. Can a poor ovarian reserve or pre-implantation genetic testing of aneuploidy data be applied to routine IVF? And what is the value? Does saving days justify added cost and freeze-all? So these are the questions that we should keep in mind when we are studying about the dual stimulation in a well-defined population. So take-home message: the DuoStim is promising, but it should remain selective. It is best considered when time is clinically important and freeze-all is acceptable. It has not yet supported as a universal routine IVF protocol because live birth superiority still remains uncertain. Thank you, ma'am.
So thank you, Arunima. It was actually a good presentation. So I have some questions if our experts allow for to ask from our presenter.
Yes, yes. And it was a very nice presentation. And I'm so happy that the young girl has done very nice justice to the topic. And Mona, I think you can continue what you wanted to know.
So Arunima, can you just tell in nutshell, what is the overall conclusion of your paper? Whether we should routinely give this DuoStim protocol to all the patients or whether in some selected patients? And what is the advantage and disadvantage?
Yes, ma'am. Ma'am, while selecting the protocol for the patient, first of all, we have to do the patient selection. We have to see whether this protocol is going to have a good outcome for that particular patient that we are undergoing the in vitro fertilization. If we are talking about the patients who are desire oncofertility or who are having poor ovarian reserve or having advanced maternal age, in them, if we use dual stimulation, it is going to have a good outcome. But if we talk about the patients who are having normal ovarian reserves and polycystic condition, ovarian syndrome condition, in those patients, if we give dual stimulation, it would end up having the adverse effects as compared to the good effects. So, ma'am, if we do the good patient selection, it will prove to be a valuable time-saving tool. And
well, what are the disadvantages which you
reduce
are
number of oocytes and
अरुणिमा, अगर नॉर्मली पेशेंट्स में सब में अगर हम DuoStim करें तो क्या डिसएडवांटेजेस हैं?
Which adverse side effect you are talking about?
Ma'am, first of all, financial burden. It will increase the cost. We cannot do the fresh embryo transfer. We have to always go with the frozen embryo transfer. Yes, ma'am. And then we should
Which
have a
are
good
adverse?
laboratory setup for vitrification and blastocyst culture to be present. And fourth one is, ma'am, limited studies. Ma'am, studies are also limited in general population as compared to the poor ovarian reserve population. So we cannot generalize the outcome which we have done on the poor ovarian reserve responders to the generalized population.
Yes, where
So
we
these are
have
some
just limited
disadvantages.
time, we should apply because we can't do then fresh embryo transfer. No, we have to go for frozen
Yes,
embryo
ma'am.
transfer. कैसे पेशेंट को काउंसिल
Frozen
करेंगे
embryo
कि
transfer.
फ्रोजन एम्ब्रियो ट्रांसफर कर रहे हैं, ये भी बहुत इंपॉर्टेंट बात है। और केवल टाइम
Yes, ma'am.
ड्यूरेशन तो जहाँ पे हमें बिल्कुल रेस्ट्रिक्टेड नहीं है टाइम ड्यूरेशन, तो वहां पे हम 2 साइकिल्स में से भी उतने एम्ब्रियो यूज कर सकते हैं। एंड द थिंग इज द लाइव बर्थ रेट, है ना। चाहे
Yes,
M2
ma'am.
ये अच्छा आ जाएगा, बट लाइव बर्थ रेट इज ऑलमोस्ट सिमिलर। अगर डुओ स्टिम करें या 2 साइकिल्स को अगर हम कंपेयर करें तो इट इज सिमिलर। तो इट शुड, आई
Similar.
डोंट
Yes,
थिंक
ma'am.
इट शुड बी जनरलाइज्ड, इट शुड बी फॉर फ्यू पेशेंट्स। देन आई वुड लाइक
Yes,
टू आस्क
ma'am.
फ्रॉम आवर एक्सपर्ट्स ऑल्सो कि मैम आप लोग कैसे करते हैं, क्या आप लोगों का ओपिनियन है, क्या सब पेशेंट्स में करना चाहिए या कुछ सिलेक्टेड पेशेंट्स में करें?
No, first of all, it has to be selected very much rightly, only for the POR cases. And then actually the oncogenic cases, the way you need a fertility preservation, that is the actual one where you really want to reduce the time and get maximum oocytes. So there the things are, and PGTA. See, because with one cycle you may be having only single oocyte. With the one cycle you're getting two or more oocytes. So that is the thing, you can go for a PGTA also, because usually these POR cases they may be having genetic problems. So we want to recognize whether we are going to, which is the euploid embryo, which is an aneuploid embryo. So that may also help. But you're right, it cannot be used conventionally in all the cases, and only in select cases we can do. Cost is a big factor. So because freezing will be required in all the cases, we cannot transfer in the same cycle. So what we are seeing in POR cases, ki sometimes if it is not an emergency, so collecting the eggs in 2 different cycles or 3 different cycles equally gives a good result.
Also in foreign national patient, madam, she has to go back. So she can't stay for their 2 consecutive months.
There is another time factor is there. So this is another factor where you have to go for dual stim. But it is not much used. So still studies have to be seen how much it gives you result.
Yes,
It's
this is another strategy. This is nothing new. Another one more strategy just to say to save the time. So this could be a faster, but definitely not better. This is what we conclude.
Ma'am, and I just want to ask, in between those 5-6 days, do you start some progesterone or any other medication and just stimulate like anything? कुछ मतलब
So,
बीच में
Mona,
कुछ?
you have to wait for it because you are just giving GnRH agonist test trigger. You cannot give SCGS trigger. For the second stimulation, you can give SCGS trigger, but for the first stimulation, trigger has to be GnRH agonist. One thing. Second thing, you don't have to give progesterone. It's like you just wait 4 to 5 days is the maximum. 4 days is minimum, 5 days is the maximum, and you start your another stimulation. Third is pooling of embryos, as ma'am said, can be done in 2 conventional cycles, and that also give you very nice pooling of the embryos, and then you get 2-3 embryos and you transfer in the same cycle. Actually उसमें क्या है कि मैंने एक कन्वेंशनल साइकिल में एक एम्ब्रियो बनाए, 2 बने, मुझे बहुत अच्छे नहीं लगे, मैंने बोला ठीक है मैं एक और करती हूँ. I kept her on long against cycle, and if I get good embryo in this also, and 2 मेरे पास थे, तो उन 3 में से सेलेक्ट करके मैं सेम साइकिल में ट्रांसफर कर सकती हूँ. मुझे फिर उस साइकिल में फ्रीज करने की जरूरत नहीं है. Which in this duo stimulation,
You
you
have to
have to freeze,
100%,
you cannot
yes.
transfer. So one patient is like Dr. Usha madam said that the patients coming from abroad, they have a very limited time. Madam, I am here for a month only. Madam, today only I have seen. बिल्कुल आज मैं यही करके आ रही हूँ कि मैडम मेरी तो 5 सितंबर की फ्लाइट है, मुझे जाना ही जाना है वापस. तो फिर आप क्या करें, तब आपको ये है कि भाई ठीक है हम फटाफट 2 स्टिमुलेशन इसी साइकिल में कर लेते हैं. या फिर वही होता है जैसे भाई बहुत पुअर ओवेरियन रिजर्व पेशेंट थे तो उनके लिए था Ashri has also recommended this for poor ovarian reserve and especially for oncofertility where you are going to preserve their eggs. तो वहां पर आपको टाइम स्ट्रेन बहुत ज्यादा होता है. यदि आपको एक ही स्टिमुलेशन में 6-7 एग मिल गए तो यू आर गुड. नहीं मिल रहे हैं तो ठीक है भैया, आप एक फटाफट सेकेंड स्टिमुलेशन, जस्ट ए गैप ऑफ 3-4 days and you do a second stimulation. So this is the rationale, but I would say one thing that Arunima, she has done a great job. She has done a very good presentation. Dual stimulation is not a conventional stimulation. It is not going to stay with us for a long time, but yes, where it is needed, you can do it because time to pregnancy, if I say, also doesn't matter because it is almost the same if you do two conventional side by side. And second thing, cost is a very, very important factor where you save a little bit when you are doing conventional protocols. ओके सो एंड लाइट बर्थ रेट्स की यदि हम बात करें तो इंफीरियर तो नहीं है ड्यूअल स्टिमुलेशन में, तो हम कर सकते हैं एज पर रिक्वायरमेंट, हम कर सकते हैं. ठीक
Ma'am,
है.
I also have a question. The जो अभी recent X-ray हुआ है, in that it was like clearly said that now DuoStim does not offer any advantage over
Yes.
BiStim, even in poor responders.
Yes,
So
yes.
like it should be only kept selective for
Yes,
oncofertility
बिल्कुल
patients,
सही,
or
बिल्कुल सही.
obviously.
जैसे ऑन्को में भी हम लोग क्या करते हैं, रैंडम स्टार्ट स्टिमुलेशन करते हैं. हम तो पीरियड्स का डेट ही नहीं देखते हैं क्या है. सर्जरी उसकी हुई, इधर कीमो होनी है, बीच का जो पीरियड है वही हमको दे दो आप 10 दिन, बस 9 दिन 8 दिन दे दो, उसमें हम इसके एग कलेक्ट कर लेंगे.
Time is critical there.
रैंडम स्टार्ट स्टिमुलेशन इसीलिए उसको कहते हैं. तो ड्यू स्टिमुलेशन हैज नो एडवांटेज ऑल्दो इट हैज एडेड कॉस्ट टू द पेशेंट, है ना, क्योंकि एक बार भी आपको फ्रीज करना है, जो बनाए दोबारा बनाए वो भी फ्रीज करने हैं. फ्रीजिंग इज एक्स्ट्रा, थॉइंग इज एक्स्ट्रा एंड टाइम. ठीक है, थोड़ा सा टाइम आप कम दे रहे हैं, बहुत ज्यादा ऐसा नहीं है कि टाइम का डिफरेंस हो रहा है. इफ यू आर डूइंग 2 कन्वेंशनल साइकिल and then second cycle you can definitely transfer in the same cycle. So I mean, you save the cost. It's just your counseling to the patient. How do you counsel? That is more important.
अच्छा मैम, एक आप लोगों के से एक्सपीरियंस पूछना था. आगीता मैम है, आप है, सब उषा मैम है. जब DuoStim आया था तो कितना बuzz था, सारा पोसाइडन 3 पोसाइडन सब में रिकमेंडेशन था. तो व्हाट इज योर एक्सपीरियंस लाइक ओवर द इयर्स?
See, I don't use too much of dual stim. I did it. I don't say that I have not done it, but I was not very happy and very. If I find two side by side conventional cycle, I I rightly say that you in conventional you have an option that you have one saved embryo and then you have one or two in this cycle. You can easily transfer in that. So that is as Sunita has done. So we have done that way, and the patient got pregnant also. So what I will recommend, basically, it is all, save it for oncofertility cases or the ones for who have to just rush, go back home, the foreign patients. Otherwise, it should not be routinely used.
तो मैम पहले तो ये
many things
कहते थे
come and
ल्यूटियल
go.
फेज यील्ड बेटर होती है, अब तो वो भी कह रहे हैं कि ल्यूटियल फेज यील्ड इज आल्सो नॉट
Varda, it is
better.
many things which come and go, है ना. Okay, it's like dual stimulation, it's like freeze all. अभी लेटेस्ट बिल्कुल यही है कि
हाँ.
फ्रेश साइकिल्स अगेन फिर आ गई कि नहीं फ्रेश ट्रांसफर करिए. अदरवाइज बीच में हुआ था कि ओनली फ्रीज ऑल ही ट्रांसफर करना है, सबको फ्रीज करके ही ट्रांसफर करो, फ्रेश करना ही नहीं है. लॉन्ग एगनेस साइकिल्स को बिल्कुल आउट कर रहे थे. नाउ देव अगेन कम बैक. सुंकारा इतना ज्यादा हर मीटिंग में एक ही चीज बोलती है, नो नो नो, फॉर पुअर एविडेंट रिजर्व आई वुड लव टू गो फॉर लॉन्ग साइकिल्स. Why to go for antagonist cycles and transfer in the same cycle, do fresh transfers. So I mean things are coming and going, है ना. ठीक है, और ये होता भी रहेगा. It's a ever evolving science.
And
But
with what you are comfortable, when
yes.
your experience is what you're comfortable in your setup and
एंड
what you
प्लस
are
हमें
seeing.
अपने जो जिस पार्ट में हम प्रैक्टिस करते हैं इसमें हमें फाइनेंशियल बर्डन बहुत ज्यादा देखना होता है, बहुत ज्यादा देखना होता है कि पेशेंट किस में कंफर्टेबल है, किस में उसको फाइनेंशियली हम थोड़ा सा कंफर्टेबल कर सकते हैं.
Antagonist cycles are working the same way as for PORs as for the agonist. Now I'm using maximum even in POR and say the milder one. Supposing you're using 2 conventional cycles, then milder stimulation and get one single.
Okay, so Mona, I think in just 2-3 lines you can just summarize and then we move ahead to the second presentation.
I just want to add that I will be leaving after Mona because I've called the pharma people Today's my
Okay, yeah, ma'am. Yeah, ma'am. Sure, ma'am. Thank you
it
so
was
much.
a very interesting talk, so I made them sit down for some time. So I will go.
Mona, are you there? Dr. Mona? Dr.
Yes, yes.
Mona?
Yes, I'm there.
I just wanted you to just
Yes.
summarize in 3 points
Uh,
and then we
Thank
move
you
ahead to
so
the second
much.
presentation.
It was such a wonderful presentation. So we discussed all the advantages and disadvantages, and we heard from experts that it should not be routinely used in each and every patient, and we should just keep this for only onco patients and the patients who are coming from abroad and have very less time. So we should not keep it as a routine to DuoStim. Now we will just move to another presentation. That is a fertility journey of a patient with McCune-Albright syndrome associated with bilateral ovarian involvement. And it is by Kim et al. And published in Fertility and Sterility Reports 2024. So this is a very clinically important case because it highlights the fertility management of 33-year-old McCune-Albright syndrome, bilateral ovarian involvement, and the patient was having growth hormone excess. She underwent IVF after endocrine optimization with lanreotide, that is a drug to reduce the GH. So I would invite our presenter, Dr. Misbah, to take us through the article focusing on the clinical background and clinical details. And just we will learn it along. Welcome, Misbah.
Thank you, ma'am. Good evening, respected teachers, my dear colleagues. I'm presenting a case report based on fertility journey in McCune-Albright syndrome. There was bilateral ovarian involvement and patient underwent IVF. It is a rare endocrine disorder. Um, in this patient, there was growth hormone excess, and that leads to insulin-like growth factor 1 excess. And ma'am, next slide, please. It is a case report of a 33-year-old woman presented with the McCune-Albright syndrome with primary infertility. Patient underwent IVF after normalization of IGF-1 with lanreotide, and outcome pregnancy was actually achieved after frozen embryo transfer, and that ended in incomplete miscarriage. Ma'am, next slide, please. Ma'am, this case is very interesting because first, it is a very rare genetic disorder where McCune-Albright syndrome is a sporadic mosaic genus 1 disorder with multiple endocrine expression. There is involvement of bilateral ovarian involvement, and multiple cystectomies were done in past, and there was growth hormone excess leading to anovulation. Next slide, ma'am. McCune-Albright syndrome, there is a gain in function mutation of genus 1 leading to polyostotic fibrous dysplasia, precocious puberty, cafe au lait spot, ovarian cyst, and estrogen autonomy, and hyperfunctioning endocrinopathies. Ma'am, next slide, please. Mechanism of infertility in McCune-Albright syndrome, there are two pathways. One is ovarian autonomy pathway. Second is growth hormone excess pathway. In ovarian autonomy pathway, there is functional ovarian cyst leading to excess estrogen production, which leads to FSH and LH suppression. That leads to anovulation. And second is growth hormone excess pathway, where growth hormone is produced in excess. That leads to increase in IGF-1. That leads to disruption in GnRH and resulted in oligo-ovulation. Ma'am, next slide, please. Our patient is 33-year-old female, presented with primary infertility for 4 years. Her cycle length was 30 to 90 days. Her BMI was 18 kg per meter square. There is presence of cafe au lait spots, polyostotic fibrous dysplasia, precocious puberty, and recurrent functional ovarian cyst. Ma'am, Prior bilateral ovarian cystectomies were done, and there is a feature of endocrine hyperfunction and also history of failed ovulation induction. Ma'am, next slide, please. Ma'am, next slide, please. Previous one, ma'am. Ma'am, previous. Yes, ma'am, next. Yes, ma'am. Diagnostic workup, IGF-1 was elevated, that is 508 nanogram per ml. Prolactin was mildly high, and MRI of head was done where there was no pituitary lesion. Fertility workup and antral follicular count was normal. AMH was normal, that is 2.31 nanogram per ml. Tubes were bilaterally patent and uterine cavity was normal. Semen analysis was normal. Ma'am, next slide, please. Ma'am, as patient presented, before that, letrozole was given for ovulation induction, but ovulation was not achieved with letrozole. But later on, lenglutide was given, which was somatostatin, which is somatostatin analog. 60 to 90 milligram was given monthly. IGF-1 fell from 508 to 319, and cycles were regularized. Ma'am, next slide, please. Ma'am, IVF was after the cycle was regularized with the somatostatin analog, that is lanreotide. Uh, Natural cycle start antagonist protocol was done. Baseline ultrasound excluded ovarian cyst and E2 T4 were low. 10 follicles were produced, 13 oocytes retrieved, 10 mature oocytes were there, and 7 were fertilized, and 3 blastocysts were frozen. Stimulation was done using recombinant FSH 250 international unit and recombinant LH 150 international unit from day 3. Dual trigger was given with recombinant HCG and GnRH equalist. Next slide, please. Ma'am, embryo transfer was done. Ma'am, first fresh embryo transfer could not be done as the beta HCG was negative and P4 was elevated. First attempt of frozen embryo transfer was cancelled because of thinning of endometrial lining, that is 4.7 mm. Second attempt was made, but that result in no conception. Third was made and pregnancy was achieved, but the outcome was incomplete miscarriage, and so DNC was done, which was uncomplicated. Next slide, please. Surgery was not preferred in this case because cystectomy or oophorectomy. If we do, then in this case, then that may reduce ovarian reserve, and patient had already underwent ovulation induction, but it could not be achieved with letrozole. Later on, when lanreotide was given and IGF-1 was normalized, later IVF was done and pregnancy was achieved. Next slide. Ma'am, in this case, oocyte quality could not be detected because if there could be genus 1 mutation. If mutation is present in follicular cell, it may affect oocyte morphology and competence, but it could not be done in this case. In this case, fertilization rate was 70%, Blastulation rate was 71%. Embryo was morphologically of good quality. Oocyte is still rated fair by embryologists, and there was no ongoing pregnancy after one fresh embryo transfer and two frozen embryo transfers. So a good number do not always equates biological certainty. Next slide, please, ma'am.
This is next. This is
Yes,
next
ma'am.
slide.
Lanreotide around conception. There is, ma'am, potential concerns regarding using lanreotide is that somatostatin analogs generally are avoided in pregnancy. Theoretical concerns for fetal growth restriction, and there is limited evidence because the McCune-Albright syndrome and pregnancy in patient of McCune-Albright syndrome, achieving pregnancy is rare. Potential benefit of using lanreotide: improve insulin-like growth factor 1 and restoration of predictable cycles. It may reduce metabolic risk from growth hormone excess, and it allows coordinated endocrine obstetric care. Ma'am, strengths of this is rare phenotype is clearly described in the study. The endocrine is there, and injury management is high. Limitation of the study is the single keyboard and divert of granulosa corona radiata G1 testing to be performed. No definitive cause of miscarriage be ruled out. Clinical impact is still endocrinopathies in McCune-Albright syndrome infertility. Preservian reserve in bilateral disease. IVF after endocrine observation. As in optic uterine.
Your voice is breaking.
Next, please. There is no issue.
Okay. This is next slide.
Ma'am, yes, ma'am. So take home message of this study is we should not treat McCune-Albright
Have you finished, Ms. Ba?
You have read all 4 points? Take home messages?
Yes, I think she has finished, and I think there's some technical glitch also. So I would like to just share what is the classical triad of this McCune-Albright syndrome. There is precocious puberty, polyostotic fibrous dysplasia, cafe ollets spots. Cafe ollets spots means in milk there is coffee. So they are generally birthmarks which are light to brown color. So if these are present along with the endocrinopathies, so this patient, for making diagnosis of this McCune-Albright syndrome, there is no genetic testing or no biopsy is required. This is only on the basis of the clinical triad. So this patient was diagnosed as a McCune-Albright syndrome, and she undergone multiple cystectomies before coming for the infertility treatment. And how lanreotide helped this case? So it just reduced the insulin-like growth factor and growth hormone so that the hormone levels were normalized and patient was induced and undergone IVF. Unfortunately, there was no live birth. So this was in nutshell, this was the case. So I would like our experts to comment on this case. Geeta ma'am.
Very rare case. It was very. Geeta ma'am is not there. She has gone perhaps. Yeah.
Okay.
Very nice case presented by Dr. Misbah. Yes, very rare, 1 in 100,000 to 1 in 1 million. And I think must have seen, but we have overlooked it because
Yes.
we see so many young girls with erratic vaginal bleeding and some stunted growth or something of that sort. I personally feel I read for this journal club only, and then I realized, oh,
maybe that was that particular case we should have seen. So, well, that also gives us a clue that any young girl, like 7 years, 6 years old girl having vaginal bleeding, and sometimes they complain also bony pain here and there, which is I just ignore. I don't relate the two things. But I, for the first time, read this very thoroughly, and then I came to conclusion that we must ask for bony pain. We must search for these skin pigmentation things also here and there, and this is not. Uncommon. This could be we come around across, but since treatment is not very much, as in this case, uh, fertility is the very remote thing. First, normal living should be the consideration. And this, she was 33 years old. I mean, think very milder form it must have been, right? Because of the mosaicism, there is very variable presentation. Could be very mild, it could be severe also. But she, this one has gone up to the age of 33 years, and she had good ovarian reserve also. She ovulated also. She conceived also. She was one of the milder forms, I suppose. But unfortunately, even she could not conceive. So this is it. We have to be more alert now.
So, Dr. Mishra, it was a very nice presentation in the sense you've chosen a very nice topic and a very nice case. I'll just share one of my patients. She was just 3 years, delivered at my place only. She was just 3 years. Her mother came, first of all, with some vaginal discharge, then mixed with bleeding. And then she kept on coming again and again that, Madam, no, she is having bleeding. Then I sent her to an endocrinologist. उसने सारा उसको workup किया, and finally she came out to be a case of adrenal tumor. Okay, and this was a cancerous tumor. She had carcinoma adrenal gland, and finally she died at the age of 7. She started bleeding at 3 and died at the age of 7. Yes, even now and then we see some young girls, children with bleeding PV, and you're very right. Unless you have something in your mind, you can't see that. So maybe we have seen few cases, but we just missed it because we never knew that this thing can be there. ये तो समझ में आता है कि प्रिकॉशस प्यूबर्टी है, बहुत जल्दी है, तो कुछ ना कुछ एंडोक्राइन ही निकलेगा, पर ये वाकई एमएस सिंड्रोम है, ये नहीं सोचा होगा. तो आई एम वेरी हैप्पी दैट मिश्वा ब्रॉट दिस केस फॉर दिस जर्नल क्लब, because everything gives you something, I mean some food for thought. तो वेरी नाइस मोना, बहुत अच्छा सेलेक्ट करा है तुमने दोनों केसेस. DuoStim इज अ वेरी नाइस डिबेट, एंड दिस केस जस्ट टू लर्न अबाउट इट कि यहाँ ये भी होता है. ठीक है.
I enhanced my knowledge today.
डेफिनेटली.
अच्छा, मेरा एक क्वेरी है डॉक्टर मोना, मतलब व्हाट वाज द लाइक रेड फ्लैग, लाइक बिकॉज इट्स रियली वेरी डिफिकल्ट टू डायग्नोज सच केसेस, such unique cases. तो यू आर सेइंग दोस कैफेटेड स्पॉट्स जो है मिल्क इन कॉफी, और मतलब आप एक्सप्लेन कर रहे हो, और बाकी चीजें
इसमें
मतलब
जो रेड फ्लैग है वो है वेरी अर्ली ब्लीडिंग. गर्ल्स स्टार्ट ब्लीडिंग फ्रॉम 6 months of age. Okay, so if a girl is coming again and again, mother is coming that her child is bleeding, she is having vaginal bleeding, you cannot ignore it. Okay. So बाकी जो चीजें उसने बताई, कैफे वाले स्पोर्ट्स है, फाइब्रस डिस्प्लेजिया इन द बोन्स है, वो सब कुछ तो है ही है. वो आपको कैफे वाले स्पोर्ट्स तो आपको बहुत पेशेंट्स में दिख जाते हैं.
और भी केसेस में मिलेंगे.
Combining these three things is very important, especially precocious puberty, which is not central, which is only peripheral. Okay, which is not because of pituitary gland. उसने बताया ना, pituitary gland में कुछ भी नहीं था.
हाँ, वो तो बताया.
पिट्यूटरी लीजन नहीं था, सेला टर्सिका.
नहीं तो क्या करते हैं सारे एंडोक्राइन वाले भी आप ही के.
These surgeries, her ovarian reserve was like maintained.
Yeah.
Multiple times ovarian cystectomies were
हाँ,
done.
हर बार ओवरी बड़ी हो जाती है,
really
थोड़ा सा पार्ट निकाल
remarkable.
दिया. इफ यू रिमेम्बर, अभी पता नहीं तुम लोगों को उसका थोड़ा बहुत आइडिया है नहीं है, जब हम लोग पढ़ते थे और पॉलीसिस्टिक ओवरीज तब भी होती थी, तो वेज रिसेक्शन ऑफ ओवरीज किया जाता था. जब बहुत बड़ी बड़ी ओवरीज होती थी तो फर्टिलिटी के लिए वेज रिसेक्शन ऑफ ओवरीज किया जाता था. इट इज जस्ट लाइक दैट. वो यही लगता है ना, बड़ी बड़ी ओवरीज है तो थोड़ा पार्ट निकाल दो.
हाँ,
वही बाद में एलओडी होने लगा. ड्रिलिंग करने लगे हम
हाँ
लोग एक आदमी।
ठीक है।
पहले तो
अब
वेज ही
तो
नहीं
एलओडी
खाते।
भी कहाँ होता है
अब
मैम,
तो
ये
बिल्कुल नहीं
बहुत
करना भी नहीं
में।
चाहिए, बिल्कुल नहीं,
नहीं, अब
एकदम
तो
ऑप्शनल, बिल्कुल नहीं करना
कंट्राइंडिकेटेड
चाहिए।
मना हो गया, अब मना हो गया वो भी
अच्छा,
कराने।
थोड़ा सा मुझे ये जानना है कि आपने ये जो लैंड्रियोटाइड दी है ये कैसे दी है और कौन से एक्चुअली इंडिकेशंस होते हैं? प्रीकॉक्सिस प्यूबर्टी इज वन, मतलब हाउ डू यू गिव इट, लाइक
I think
द एंडोक्रिनोलॉजिस्ट गिव इट?
endocrinologist actually gave it. It was not, I don't think it was given by some gynecologist, but yes, we should keep in mind those atypical endocrine disorders also. ऐसा नहीं कि हम केवल इनफर्टिलिटी को ध्यान में रखें, वी शुड ऑल्सो
हाँ
कीप इन माइंड कि ऐसे ऐसे एटिपिकल डिसऑर्डर्स भी हो सकते हैं, एंड शुड टेक इन कंसिडरेशन ऑफ द एडवाइस ऑफ अ एंडोक्राइनोलॉजिस्ट फ्रेंड्स ऑल्सो. दिस इज ऑल्सो एन इम्पोर्टेंट
हाँ,
पार्ट.
दिस इज
एक्चुअली मैं
एक्चुअली एन आई
लाइफ
ओपनर
लॉन्ग
फॉर
पास्ट
अस
में,
आल्सो टू थिंक आउट ऑफ द ब्रैकेट,
हाँ
कि अगर कोई ऐसा केस आए तो इट इज नॉट लाइक
यस, अभी पास्ट में आई डायग्नोज ए केस ऑफ कंजेनिटल एड्रिनल हाइपरप्लेजिया, बिलीव मी आई गॉट ए कॉल फ्रॉम पीजीआई कि डॉक्टर आपने डायग्नोज कैसे किया, ये बताइए आप, आपके दिमाग में कैसे आया, आप लोगों के दिमाग में ही नहीं आता है, आपके दिमाग में कैसे आ गया कि ये कंजेनिटल एड्रिनल हाइपरप्लेजिया है। हर पेरेंट्स एंड द डॉक्टर हु रेफर्ड टू मी, दे केम टू माय हॉस्पिटल कि डॉक्टर साहब आपने कैसे डायग्नोज कर लिया, ये दे वर सो थैंकफुल टू मी एंड आई गॉट ए कॉल फ्रॉम पीजीआई कि मैडम ये बताइए आपने कैसे सोचा, जिससे कि हम बताएं
नहीं
लोगों
नहीं।
को कि हाँ सोच भी सकते हैं ये चीज, कंजेनिटल एड्रेनल हाइपरप्लेजिया। तो आई मीन एवरीबडी इज लाइक पीसीओ है, पीसीओ है, मोटी हो पतली हो जाओ, है ना,
हाँ
ये
हाँ
सब
हाँ।
चीजें, हाँ वेट कम करो, वेट कम करो, एक ही चीज के पीछे पड़े रहते हैं। तो वादा इज लाइक आउट ऑफ द बॉक्स थिंकिंग, है ना, कि आप सोचें थोड़ा सा अलग जाके। अब
एंड
जैसे
अबाउट दिस जीएनएस म्यूटेशन, इसका क्या होता है, मतलब इज देयर?
जीन एस म्यूटेशन होता है, बट ये ऐसा नहीं है कि इसको डायग्नोज करने के लिए हम
हाँ
म्यूटेशन करके डायग्नोज करें. इट इज ऑन द क्लिनिकल बेसिस.
हाँ, और ये
ओके।
अपने आप ही हो जाता है, मतलब इट्स नॉट जेनेटिक और एनीथिंग, ये अपने आप ही हो जाता है।
मिसबा आ गई। मिसबा बताओ, जीन किस क्रोमोसोम पे होता है?
देख के
नहीं,
बता दो.
लाइक ओके, दिस इज अ पार्ट ऑफ जेनेटिक्स एंड इनफर्टिलिटी मैम, सो
हाँ,
आजकल इतनी बातें हो रही
क्रोमोसोम
हैं।
नंबर 20 पे होता है, तो ऑटोसोमल है वो, और स्पोरेडिक होता है, पोस्ट डाइगोटिक है, तो
हाँ हाँ।
इसलिए इनहेरिटेड नहीं होगा, इट इज स्पोरेडिक रैंडम थिंग, हो
स्पोरेडिक है,
जाता है।
ओके।
बस यही है।
हो गया।
तो व्हाट डू यू थिंक वाज द कॉज ऑफ मिसकैरेज?
अरे, तो इसके कारण सब कुछ डिफेक्टिव था ना, ग्रेनुलोसा सेल डिफेक्टिव थी, उस साइड डिफेक्टिव बना होगा, एम्ब्रियो बना होगा, डिफेक्टिव बना होगा, कोई इसका ये पीजीटी तो हुआ नहीं था ना, पीजीटी वगैरह कुछ हुआ नहीं था।
नहीं नहीं मैम, मैं डिफेक्टिव तो मैम, एक बार ब्लास्ट बन गया तो फिर क्या डिफेक्टिव, मतलब एन्यूप्लॉइडी आई एक्सेप्ट, एन्यूप्लॉइडी होगी, लेकिन अगर ब्लास्ट बना है तो।
न्यूक्लियोइड के अलावा भी तो बहुत तरह के डिफेक्ट होते हैं भाई।
इंड्यूस,
न्यूक्लियोइड इज वन थिंग।
ensure the quantity but not the quality. इसमें oocyte quality is not that good that it can give rise to clinical pregnancy. I think that is the reason.
कायदे से उसकी
नहीं
ग्रेनुलोसा
तो
सेल की बायोप्सी होनी
तुम्हारा
चाहिए
ब्लास्ट तो
उसका।
बना था ना?
But the quality was not good, I think.
Varda, do all the blasts give you pregnancy? Do all
No,
euploid
no, no. I
blasts give you
completely
pregnancy?
accept the quality is, but blast bana to not necessarily oocyte was bad. I accept the genetic point
Yes.
of view,
और ऊपर से
but
एंडोमेट्रियम भी याद करो, इसका बहुत थिन था, 0.4 और एमएमई पहली बार था, दूसरी बार ये लोग कर पाए थे, तो एंडोमेट्रियम भी डिफेक्टिव हो सकता है। और
हाँ, एंडोमेट्रियम हो सकता है बिकॉज
Endometrium can
सारा
also be there,
हार्मोनल
right?
मिल्यू उसका डिस्टर्ब्ड है।
यस।
नहीं, डेफिनेटली। और लॉन्ग टर्म क्या होता है इन पेशेंट्स में, डॉक्टर मोना आज आप सब बता ही रहे हो तो क्या मतलब इनका है?
मैम यहाँ पे हैं. आई हैव पर्सनली नॉट सीन सच काइंड ऑफ अ पेशेंट. मैम यहाँ पे हैं, मैम से ही हम लोग थोड़ा सा ज्ञानवर्धन करते हैं कि मैम इस तरह का कोई आपने पेशेंट देखा है क्या, कोई मैक्यून एल्ब्राइट सिंड्रोम या कोई
नहीं नहीं
ऐसा
नहीं,
और?
मैंने ये एमएस सिंड्रोम का पेशेंट नहीं देखा है, व्हाट आई हैव सीन precocious puberties I've already shared with you.
हाँ जी
One
जी.
is like this girl who had adrenal gland tumor and they turned out to be malignant and she died. Another was very young child of 1 year, maybe 1.5 years. She kept on coming repeatedly to me for with uh, bleeding, spotting, and then finally she disappeared. She lost for follow up. मुझे स्पॉट्स का तो बिल्कुल याद नहीं है, पर ये बिल्कुल पक्का था कि इट वाज अ वेजाइनल ब्लीड। ओके, तो बाकी अराउंड 9 इयर्स की बच्चियां तो बहुत आई हैं विद प्रिकॉशियस
अभी
प्यूबर्टी।
तो मीनार्की का एज ही हो गया है, 8 साल 9 साल।
हाँ, 8 साल की भी आ रही हैं अभी।
हाँ हाँ, मैंने भी देखा
एक्चुअली
है।
लेटेस्ट जो है मोना, क्या कहते हो, इज इट लाइक 9 और अब 8.5 पे भी हम लोग लेने लगे हैं?
मैम 8.5 आई थिंक हम लोग कट ऑफ लेते हैं अब
अच्छा,
इससे।
8.5 का कट ऑफ हो गया है, 9 तक का तो था, अब 8.5 भी कट ऑफ हो गया है। ओके।
हम आज के मॉडल में 9 इयर्स तो एक तरह से मान लीजिए कि
हाँ,
नॉर्मली टाइप से हो गया
9
है।
ईयर्स तो एक्सेप्टेड हो गया है, पर क्या
Common.
8.5 भी हम लोग वो मान लेते हैं कि ठीक है? इज इट ओके? ओके, so I have not seen any MAS case, but I have seen these girls with vaginal bleed at a very very early age. This I have seen in my practice of
And
32
I have
years. I have
seen
seen.
8 years तक तो मैंने
आई
देख
हैव
लिया।
सीन ऑफ वॉन ग्रुम्बैक सिंड्रोम।
हाँ
तो
हाँ
वो प्रिकॉशियस प्यूबर्टी था एंड द पेशेंट, वैसे तो क्या कहें उसको कि शी केम इन एडवांस्ड प्रेगनेंसी। तो तब हम लोगों ने उसको रेट्रोग्रेड में देखा तो उसको सीवियर हाइपोथायरॉयडिज्म था। इट वाज ऑन ग्रुम्बैक सिंड्रोम, हमारे मेडिसिन में पहले से फॉलो हो रही थी और उसका हाइपोथायरॉयडिज्म जब करेक्ट हुआ तो हाइपोथायरॉयडिज्म करेक्ट होते ही वो कंसीव कर गई और हमारे पास आई थी एंटीनेटल वर्कअप के लिए एंड वी डिड द सिजेरियन एंड बोथ मदर एंड बेबी वर सेव्ड। सो दैट इज अनदर एटिपिकल केस वी कैन टॉक ऑफ। तो इस तरह से नाउ एंड देन इस तरह के पेशेंट्स मैम आ जाते हैं, मिल
हाँ,
जाते
बस
हैं।
बस बिल्कुल सही बात है। बट इट्स नॉट ए कॉमन, इट्स ए वेरी वेरी रेयर केस। ये मैं यही कह रही हूँ मिश्रा से कि बहुत अच्छा केस सेलेक्ट किया उसने, बहुत अच्छा
हाँ।
था। इट वाज ए फूड फॉर थॉट। हम लोगों ने भी पढ़ा, सोचा कि हाँ यस व्हाट इज इट ऑल अबाउट, और तब दिमाग में आया कि हाँ हाँ कभी कभी बच्चे इस तरीके के आए हैं जो ब्लीड करके आए हैं, एंड वी नेवर थॉट ऑफ इट कि एमएस भी हो सकता है।
ऐसे ड्वार्फ तो बहुत देखे ना, ड्वार्फ लेडीज आती हैं 3 फीट की, आई लेडी फुल टर्म प्रेगनेंसी लेकर के, तो उनमें तो फर्टिलिटी एकदम मेंटेन रहता है। दे हैव गॉट डिफरेंट ओरिजिन, मतलब कॉज पे डिपेंड करता है कि आगे क्या होगा उनका। इसमें
So thank with this we conclude the session, and I'm really very thankful. Is Achal here for the vote of thanks? Achal, I cannot see her. So again, thank you so much, wonderful speakers, and Dr. Mona, the whole KGMU team, our experts, Sunita ma'am, Usha ma'am, Geeta ma'am, all of you. And because of you only, we could have this such a successful journal club. And we look forward to more such insightful journal articles which we can discuss and enlighten ourselves in future. So again, thank you so much.
definitely
With
very
this,
interesting. It was very really
Thank you so
interesting.
much,
Thank you so much.
Dr. Varda,
thank you, ma'am.
ma'am, Sunita
Thank you.
ma'am, thank you all.
Thank you Mona, thank you Mishra, thank you Arunima, and special thanks to Vada.
थैंक यू सो मच।
थैंक यू
आप सबको
और हार्ड
कोटि
वर्क
कोटि
एंड दोबारा मेहनत करने के
ओके मैम, फिर मिलते हैं आगे।
लिए।
गुड नाइट, गुड
बाय।
नाइट,
Bye.
हैप्पी वीकेंड, हैप्पी वीकेंड।
थैंक यू।
थैंक यू मुकुल, थैंक यू सो मच for making the whole thing seamless.
Thank you.